Just let me know if you can see my screen, please. Excellent. Okay, let's start this. Well, today we finished up so far the following subjects. We finished cardiology, endocrinology. We are also done with endocrinology and gastroenterology in addition to renal. So from the systems, we only have hematology oncology, which is a short system, the same with musculoskeletal. Neurology is a little bit long, but it's not as long as microbiology. Microbiology was the longest subject yet. Psychiatry is super small subject. Reproductive is a little bit long, but it's not difficult. And respiratory is one of the easiest subject of the whole book and the shortest between all of them. So yeah, we are like, after I finish today class, we will be done with more than 50% of the book, which is good. And also we will be done with the most of the difficult stuff, which was my goal from the beginning, to get rid of the difficult stuff in the beginning and keep the easier things for later. Okay, some people say that my screen is stuck. Okay, this thing is happening again, so let me make a Zoom meeting. 1 second, please. Okay, so I believe we can keep going. Okay, so I believe we can keep going. It's recording and we can continue. So as I said, like we are done with more than 50%, especially the difficult stuff we are done with. I will start now approaching a different methodology. I will be finishing cellular with you. After that, we'll finish pharmacology. By this way, we will only have nutrition and metabolism left. Nutrition tend to be super easy, metabolism tend to be super difficult. So we'll finish nutrition after pharm, and after that we'll do one of the systems depending on your choice, and we'll finish it up with biostatistics. Will be the last thing I explain for you guys before the end of the course, because I can hear myself, guys. Somebody should mute himself. Okay, so yeah, basically what the plan is to finish cellular for now, follow it up with pharmacology, and then we'll see what we are going to do, but biostatistics will be the last thing. So let's take a look at cellular biochemistry for now, and let's finish it up. Okay guys, I remember that I already explained some stuff for you. I remember that the last thing in cellular that I explained was the microtubules, according to the notes. So today we will have to speak about cilia structure. Did we discuss previously cilia structure with each other, guys? No. Okay, because on my notes written that the last thing was this, so yeah. Okay, cilia structure, it's going to be something like this. When we spoke about the microtubules, I have told you guys that each microtubule, the microtubule is made out of a microsubstance called tubulin. Tubulin has two subunits, alpha subunit, beta subunit. So this alpha and beta subunit help to form the tube of the microtubule. Okay? So the tubulin is the building unit. So here they say that the cilia is made out of 9 doublets plus 2 singlet arrangement of microtubule. What does that mean? Well, doublets mean 2, singlet means 1. So we have 9 2s and 2 1s. Well, what does that mean? Let's take a look. So this is what they mean by doublet. As you can see, it's the alpha and the beta subunit going together, you know? And let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9. Oh, okay, 9. So that's 9 doublets. What about the 2 singlet they said about? Well, that's 1, that's 2. So as you can see, it's made out of 9 doublet and 2 singlet. So that's what it means. It's the number of the tubulin subunit made out of. Okay, sorry, the number of microtubule that the cilia is made out of. You must know one thing. A cilia, what is a cilia? A cilia is a structure that can move, which can be utilized to do a lot of things. One of the function of cilia, movement, absolutely. So we can find cilia, for example, any organ. Can somebody tell me an organ that we find cilia in? Come on, any organ. Well, cilia. Well, okay, for the cilia, oh yeah, absolutely. You can find them inside of the fallopian tube in ladies, and the function of them is to move the oocyte, right? To move the oocyte from the ovaries towards the uterus. We also can find cilia inside of the lung. Why? Because they participate in the mucociliary apparatus to clear out debris from the lung. We also can find cilia in the intestine to help move stuff, you know? So the cilia are super important for movement. This is cilia, and the photo you can see here is just a cross section at this level. Why I'm telling you this? Because a cross section at this level will be different from a cross section at this level. Okay, so this is a cross section number 1, this is a cross section number 2. As a cross section number 1, okay, we said it's 9 multiplied by 2 multiplied by, plus, this is just a weird formula like people in science used to, they like it, it's stupid, but they like it. 2 multiplied by 1, what does that mean? 9 doublets and 2 singlet, that's what it means. Okay, so now the other section, which is at the basal body layer. So the basal body, which is the lower one, basal body, base of the cilium below the cell membrane, consists of 9 microtubules triplet with no central microtubules. Okay, so it's going to be, oh, can you see them? It's like 1, 2, 3. So together, 1 triplet, 2 triplet, 3 triplet, 4 triplet, 5, 6, 7, 8, and 9. Okay, that's it. 9 triplets at the base. Good. So axonal dynein, the dynein arm again. The dynein arm was responsible of doing what? Anterograde movement or retrograde movement? Excellent, it was retrograde movement. So axonal, yeah, just a second. Axonemal dynein, the Atpase that link peripheral 9 doublets and causes bending of the cilium by differential sliding of the doublets. This might be difficult to understand, but basically the cilia has a movement, and you must master how does the cilia move. It's not really important for the exam, but it's really important for the sake of understanding what happens, you know. So let's take a look about how it does move.
Wherever they occur, have the same underlying structure. They are made up of fine strands known as microtubules.
So as you can see here, we have the microtubules, and we do have this structure we spoke about. Yes, let's count 1, 2, 3, 4, 5, 6, 7, 8, and the 2. So now you can look at the base of them, and yes, see, they can help make the microtubule can help make the flagella. They can make cilia. Cilia is not the same as the flagella, by the way, guys. Like one bacterial cell can have millions of cilia, but one flagella. Okay, so yes, as you can see, the dynein arm contraction helped to move the cilia around. Okay, so let's go back to this. Now we have also a concept speaking about ATPase that link peripheral 9 doublets and causes bending of the cilia, causes differential sliding of the doublets. So what does that mean? If we have this cilia here at the basal area, we have the dynein there, which can lead to the bending. Okay, so it's going to bend over like this, which is going to lead basically to movement. Okay, gap junction enables coordination of the ciliary movement, which means a gap junction, it's a connection between two cells. Remember, it's just an ion channel, and this ion channel is able to pass the depolarization from cell 1 to cell 2. If you pass the depolarization from cell 1 to cell 2, you will have the exact same motion as cell 1. It will be minorly delayed, but kind of synchronized, happen after each other. So this is the cilia. They are connected by gap junction, of course. And yeah, this one is going to go this way, like, you know, have this motion. The next one is going to follow it because of the gap junction depolarization. The second one is going to follow, and the second one is going to follow, and like that. So Cartagena syndrome, and what does it mean? In which system did we speak about Cartagena syndrome? Cardiology, absolutely. Cartagena syndrome, it's an autosomal recessive dynein arm defect. They like to ask about the dynein arm defect, and yeah, it can precipitate into an immotile cilia. So that will lead to dysfunctional in a ciliated epithelium, which is going to lead to so many symptoms. The findings are as follows. Developmental abnormalities because of poor migration and orientation. For example, you cannot have correct, like, left to right orientation. It does not happen correctly. For example, in a normal human being, the heart is big towards the left. But in patient with the Cartagena, this is not true. So yeah, everything will be located vice versa, so they are going to have situs inversus. As you can see, the cardiac shadow is going to the other side. So hearing loss is due to dysfunctional of the auditory tube. So they will have poor cilia in it, which also can lead to some type of obstruction sometimes. Also, recurrent infection like mastoiditis, sinusitis, and ear infection. Why? Because they are unable to clear out any form of infection, right? The mucociliary apparatus is totally dysfunctional. Okay, so the next one is a bronchioctasis. Because they cannot clear out the debris and the pathogens, they will have recurrent pyogenic infections. Recurrent infections of the lung and chronic inflammatory reaction inside of the lung for a really long period of time precipitate to a condition called the bronchioctasis, in which the lung structure gets destroyed and becomes irreversibly damaged, and basically start to create really dilated bronchi and destroyed lung parenchyma. Also, they can have infertility and increased risk of ectopics due to dysfunctional fallopian tube cilia, as somebody said today, in which there will be an impossibility in the lady to move the, if we say this is the ovary, right? So this is the ovary, this is the uterus, And if we have fertilization here, it will be impossible to move the fertilized zygote, we call him, to this side, which is going to lead basically to ectopic pregnancy. Okay. Also, immotile spermatozoa. Why? Because the head is fine. The head has the acrosome, he's good. The neck is fine as well. But the problem is with the tail. Why? Because the tail is made out of microtubule. And he's functional only with the dynan arm. No dynan arm, no movement, right? So this is actually a really important reason as well why we have immotility of the sperm. But by the way, if I do IVF, which is in vitro fertilization, which is injecting the sperm into the oocyte, is it possible to get that man a boy? Yes, absolutely yes. So the lab finding include decreased nasal nitric oxide test. So some people might be like, wait a second, how the hell is nasal nitric oxide even related to this? Nasal nitric oxide test is a form of a test that we do that tell us the function of the cilia, if it exists or not. Okay, so it's a quantitative type of measure in which I will just show you how it goes. Yes, so as you can see, basically it's a quantitative type of measure that can tell us if the cilia are functioning or not. If they are functioning, they are going to have some amount of nitric oxide. If they are dysfunctional, we'll have a different amount of nitric oxide, and according to that we can say if it's functional or not. If it is not functional at all, this means that the cilia are not working. The cilia are dysfunctional. So it's just a quantitative measure that helps us to say if the patient cilia are working or not. So the next thing is about the sodium-potassium bump. So sodium-potassium ATPase is located in the plasma membrane. So if this is the cell, this is the plasma membrane, and here we have the sodium-potassium bump. Remember, since it is an ATPase, will it be bumping towards the gradient or against the gradient? Against the gradient, absolutely. If it's consuming ATP, it must be against the gradient. So it's located at the plasma membrane with an ATP site on the cytosolic side. So for each ATP consumed, 2 potassium are going into the cell, and thus during the dephosphorylation of the cell. So wait a second. If this is the bump, the potassium is going to the inside, right? Against the gradient. And the sodium is going to the outside. Yeah, so the potassium goes in during the dephosphorylation of the bump, while the sodium goes out during the phosphorylation of the bump, as you can see here. So here we are phosphorylating, sodium goes out. Dephosphorylating, potassium comes in. So, yep, cardiac glycoside lead to basically inhibition of this channel. When this channel is inhibited, the amount of sodium is going to be much higher inside of the cell, which is basically going to inhibit another bump located here, which is called sodium-calcium bump. And thus, the calcium inside of the cell is going to increase, and that increases cardiac contractility. We explained this concept in cardiology. So again, inhibition of the sodium-potassium ATPase lead to indirect inhibition of sodium-calcium exchange. Why? Because we already have a high sodium because of inhibition of the bump. Thus, no need for the calcium to go out of the cell anymore. So the amount of calcium in the cell is going to increase, leading to more cardiac contractility. So glycosides such as digoxin, do they improve the mortality? Yes or no? So no, they do not improve the mortality. They do not improve the mortality. Remember, the drugs that improve the mortality are the drugs that inhibit the function of aldosterone, angiotensin 2, or catecholamines. So this includes spironolactone, beta blocker, ACE inhibitor, ARBs. Anything that works on the RAS system basically is good for mortality. Anything that does not work on the RAS system is like, yeah, symptomatic, it's good, but it does not improve the mortality. So symptomatic treatment is not bad, guys. It's at least like your patient can keep going. He will not be bedridden. So Still, something good. So the collagen. Collagen is the most abundant protein in a human body, extensively modified by translational modification. So if you remember, I told you after we make a protein, we have to trim it, we have also to do this covalent changes in which we like put some glucose, hydroxylate, acylate. We will see what we will do for collagen. So yeah, that's we call post-translational modification. So organizes and strengthens the extracellular matrix. So we have different types of collagen. We have type 1, type 2, type 3, type 4, and type 5. So the type 1 is the most common. It's 90% overall, and it's most likely to be in the bone. Yeah, that was famous back in my time. 1-1, so it's in the tendon and in the bone. So it's in the bone, made up by the osteoblast, destroyed by the osteoclast. And in the skin, tendon, dentine of the teeth, and fascia, and also the cornea. The eye structure are super important. You will notice that the cornea is type 1, the vitreous body is type 2, the lens is type 4. So as you can see, and the choroid layer of the eye is type 3. So you can see that the eye structure comes from totally different origins. I mean, totally different types of collagen. So, okay, so here they write late wound repair. I will keep this for later. I will explain it when I explain the type 3. Okay, so as you can see, overall, the more hard type of collagen is type 1 collagen. It will be decreased production in cases of osteogenesis imperfecta type of a problem, and patients with osteogenesis imperfecta also have a problem in the post-translational modification of glycosylation, which is a procedure I will be explaining in a moment. The type 2 collagen, it's cartilage, so it's in the cartilage, including hyaline type of cartilage, vitreous body of the eye, and the nucleus pulposus. Nucleus pulposus. You know that I like this question. So where does the nucleus pulposus come from? Any idea where does the bulbous okay, so I will just tell you. It comes from the notochord. The notochord, if you remember, it was coming from a mesoderm, and the function of the notochord was originally to make the sonic hedgehog factor, which used to stimulate the neuronal tube to form. So that's also type 2 collagen, I mean after birth. So the type 3 is the reticulin, which also exists in the skin and also in the blood vessels. You must know about the type 3 and the blood vessels, and in the uterus as well, and fetal tissues as well. As you can see, it can be existing in cases of early wound repair. So if we have a wound, this wound initially is going to have type 3 collagen, which is not the best type of collagen, you know, it's weak. So after sometimes the type 3 collagen is going to be converted with type 1 collagen. So it's originally type 3 and then type 1 collagen. So why we converted to type 1? It's a more tensile type of collagen. But I have a question to you. What is more stronger, normal skin or scar tissue? So this is a common tricky question. It's not scar tissue. It's actually normal skin. In the USMLE, I personally got it incorrect. In the USMLE, they like you to think, oh, it's a scar tissue will be much more tensile. But actually it's not. Scar tissue is 70 to 80% as tensile as normal skin. Our skin has, like, just a second, I will show you exactly where you can find it. Because for now you are like, no, I had this scar and it feels so tough. But no. Actually, just a second, let me find the sentence. Scarring. Ah, I believe it's an inflammation. It must be an inflammation. Just a second. Okay, as you can see, here they write 70 to 80% tensile strength regained at 3 months. So even after a long period of time, and when we convert the type 3 to type 1 and all of that, the scar is only 80% tensile. It's not 100 even. Okay, anyway, so we'll continue speaking about this topic later, but let's now continue with our cellular biology and collagen and how it goes. So for the collagen also we have the type 3, and it's mostly in the vessels, and it's really famous in Ehlers-Danlos Syndrome. Make a quote. Oh yeah, they already put it. Vascular type of Ehlers-Danlos Syndrome. Ehlers-Danlos Syndrome have many subtypes. For the USMLE, you only have to know 2 of them: vascular type and musculoskeletal type. Vascular type, it's a defect in the type 3 collagen, and the musculoskeletal type, it's a defect in the type 5 collagen. So now the type 4 collagen. The type 4 collagen is mainly located in the basement membrane, in the basal lamina, and also in the lens. If you confuse which one it is in the lens, it's easy. Lens is 4 letters, so that will be type 4 collagen. So type 4 is under the floor, so that will be the basement membrane. This is super important because for the sake of a tumor cells to penetrate and lead to metastasis, it must penetrate the basement membrane. Remember, if these were 2 epithelial cells, and these 2 epithelial cells will have this basement membrane under them. For the sake of a cancer cells to move it through and come down, first of all, it has to downregulate the connection between these cells, which is also known as E-cadherin, and after that, it's going to continue and must penetrate the basement membrane, which is made out of collagen type 4. And for doing so, it will need metalloproteases, which are also known as collagenase. After it penetrates all of that, it's going to attach to something called laminin and fibrinolactin. After attaching to the laminin and the fibrinolactin, it's going to move to the blood vessels and metastasize to other organs. This is the short story of metastasis. I'll be repeating this story maybe 6 to 10 times during our classes, but eventually you must master it. So the type 4 collagen, if you remember, when we spoke about the kidney, there was one case called Albert syndrome. In Albert syndrome, we had a total defect of the collagen type 4, in which it was totally inheritable. We did not have the collagen type 4. If you check for antibodies in that disease, will you find any antibodies? Exactly, can't see, can't be, can't hear a bee. So no antibodies, absolutely. It's just a defect in the collagen. What about Goodbasser syndrome? Does Goodbasser syndrome have antibody? Absolutely, yes. Okay, exactly. And so he will have antibody against the basement membrane of the lung and the kidney. So now we speak about the collagen synthesis and its structure. So for the collagen synthesis, we have many steps, 6 steps. Just make it simple. First of all, you need to know which cell make the collagen. It's the fibroblast. And it's going to start like everything else from the nucleus. So from the nucleus, we will have a gene that is going to encode mRNA by a process called transformation. And after, transcription. And after transcription, we have the mRNA. It's going to the rough endoplasmatic reticulum, which has the ribosomes. And there we are going to make the collagen, which is a protein. And also we are going to make the what? The post-translational modification. Not all of them, but most of them. So, okay, we got ourselves a collagen. So they write here the synthesis. A translation of collagen alpha chain, a pre-collagen, which is the most initial type, is usually made of 1 glycine and an X and a Y. So X and Y, we don't even know what these are. They can be either proline or lysine, but we don't know which time it will be lysine, which one is going to be proline. So you must know, and this is a common question. They can ask you, Which of the following is the most common amino acid in the structure of collagen? Is it a glycine, is it a proline, or is it lysine? Which of the following, again, which of the following is the most common type of amino acid in collagen? Is it a proline, lysine, or a glycine? Absolutely correct. It is a glycine. It is a glycine. It must be glycine. So for collagen is 1/3 glycine. A glycine content of collagen is less variable than lysine and the proline. However, a hydroxyproline is the one used for a quantification of the collagen. But it's actually easier to quantify. That's why we do it. But to be totally fair, the best one is glycine. Why? Because it's fixed. It's a fixed amount. So, okay, we have a pre-pro collagen. So the pro-alpha chain backbone of the collagen is one glycine and proline and lysine, variable of course. The next process is hydroxylation. So the hydroxylation process is putting an OH group on two amino acids, which are lysine and proline. Keep in mind that the glycine is not touched in this process, so there is nothing altering the glycine basically. It's just the proline and the lysine. So hydroxylation of a specific proline and lysine residue, and it requires vitamin C. Okay, and the deficiency is going to lead to scurvy. Yep. Scurvy is a vitamin C deficiency. Remember, the most important symptoms of scurvy is the gingival bleeding. And most likely it's going to be in someone who's not consuming fruit. Which person is not going to consume a fruit in the US? Sailor, that will be in 100-year-old question. The USMLE actually started at the 1950. So, yeah. It's actually going to be like, not kids, no. It's going to be either teenagers who started to live alone not long ago. So they eat only cereal and milk and that's it. Or in really old men who had recently the death of their partner and they are living alone, so they only eat hot dog and tea. Or also we have, and soda, sorry, hot dog and soda. Or it can be the lady who's going on a really strict diet, and which she's going to have like a really strict diet, only drinking tea and eating toast. Okay, so that will be all of the cases of scurvy. The next one will be the glycosylation. Glycosylation of a pre-alpha chain hydroxylysine. Notice, the hydroxylation happened to both proline and lysine. So now we have hydroxylysine and hydroxyproline. But the glycosylation process is only happening to the hydroxylysine. Again, initially 3 amino acids, glycine, proline, and lysine. Then hydroxylation happened to only 2 of them, lysine and proline. So now we have hydroxylysine and hydroxyproline. From these 2, we only have adding of a sugar to one of them, which is the hydroxylysine. So glycosylation of the pro-alpha chain residue and the formation of the pro-collagen via hydrogen and disulfide bound, which creates the triple helix. Notice here. Like at glycosylation, we have only one structure of the glycogen. But after we added the glucose, now look what happens. It sticks them together. I just used to imagine it like a glycosylation process is adding sugar, so it's kind of sticky. So it sticks the 3 helix together, making something called procollagen from the pre-procollagen. Okay. So that helped in the formation of the triple helix and is defected in the Osteogenesis Imperfecta, which is a defect in type 1 collagen. Okay, good. So far, I want you to know, and you must know this, pre-procollagen is converted to procollagen in the rough endoplasmatic reticulum. In another word, if they ask you, where does the process of hydroxylation and the glycosylation happens? The answer is it happens in the rough endoplasmatic reticulum. Okay, now the exocytosis. The exocytosis of a procollagen into the extracellular space. So it exists from the basically the rough endoplasmatic reticulum to Amazon, which is the distribution center, Golgi, and from the Golgi it just escapes out to the extracellular space. Okay, we are at the extracellular space finally. So they write here exocytosis of a procollagen into the extracellular space. In the extracellular space, we will have something else happening, which is another form of post-translational modification, which is the proteolytic processing, which is trimming it. So it's a cleavage of the disulfide-rich terminal region of a procollagen. So it's removing the N-terminal and the C-terminal, okay? Insoluble tropocollagen will be made. Now, so we got the procollagen. From the procollagen to convert it to tropocollagen, if they ask you where this is occurring, do not say cytosol. They love to trick you about that. The correct answer is extracellular matrix, okay? It's in the extracellular space. Good, so we are done. We have a perfect collagen, tropocollagen, sorry, that is ready. Now we have to make a collagen fiber out of it. To make a collagen fiber, we need to get this triple helix, connect a bunch of them together, and for the sake of doing that, we have to do the process of a cross-linking. The process of a cross-linking involves the following. Reinforcement of many staggered tropocollagen molecules by covalent lysine and hydroxylysine cross-linkage by copper-containing lysyl oxidase. So the enzyme that helps for the cross-linking, which is the connection between the tropocollagen, it's happening by an enzyme called lysyl oxidase. And for the sake of this connection to happen, you need copper. Okay, well, we learned the disease in GIT in which we had too much copper. What was that disease? It was Wilson disease. Yeah, now today we are going to speak about a disease in which we have too less copper, which is Minky's disease. So cross-linkage of collagen increases with age. That's why old ladies have wrinkles. And the problems with the cross-linking can lead to something called Minky's disease, which is a disease we are going to speak about today. Okay, so the last thing before the break, let's speak a little bit about Osteogenesis Imperfecta. It's a type 1 collagen problem. Remember, in Osteogenesis Imperfecta, the problem was in the glycosylation process. And people with Osteogenesis Imperfecta can have multiple disorder, including genetic bone disorder, also known as a brittle bone disease, caused by variable problem. Guys, when you read this stuff, this is collagen type 1, subtypes A1 and A2. So the COL stands for collagen. But for the sake of making it easy, we just say cola 1. That's it. So the problem in Osteogenesis Imperfecta is in cola 1. And yeah, most common form of autosomal dominant with decreased production of otherwise normal type 1 collagen. So, okay, we have screwed type 1 collagen. We don't have a lot of it. And we remember that it was really important for bone formation, also in the cornea formation of the eye. Okay, so let's take a look at the problems that can occur. Multiple fracture and bone deformities, which is just like common sense because type 1 collagen makes the bone. Also, after minimal trauma. For example, during birth, after birth, you can have a baby with multiple fracture, and that doesn't make sense. Because, okay, we might have a clavicle fracture in a baby, but not so many fracture. By the way, if you deliver a baby and he has a clavicle fracture, just reduce it in the place. You don't have to treat it. It will correct itself alone. Just reduce it into its place, and babies can correct it alone. No needs for orthopedics. Yep. Children are interesting. Guys, for example, even if you have this baby, the patient has a brain tumor in one area of his brain this big, and you remove half of his brain, interesting stuff, it will regrow. Yep. It will regrow, which means that he will regain all of the brain tissue and brain function that he had previously. The patient with osteogenesis imperfecta can have a blue sclera, and this is high yield. You must know why they have the blue sclera. Basically, see this outer tissue, the sclera, is made out of collagen type 1, okay? And because of the osteogenesis imperfecta, it will be super thin. If you look at your hand, you can see the veins under your hand. The veins on your hand looks blue. But in reality, if you open your skin and look at the veins, they are red. So how come you look at them and see them blue? The reason is all about light refraction, okay? So because of that, you see them as blue. The same idea of the eye. The sclera is super thin, so you see a layer of the eye called the choroid under it, which makes it look bluish. So this can be seen in osteogenesis imperfecta. It's due to a defect in the collagen of the sclera. Some form have also tooth abnormalities, including so they have teeth that look clear. They look like transparent. I will have to show it to you. Just a second. Dentinogenesis imperfecta. So the dentinogenesis imperfecta, it's like they can look either like crashed like this. No, this is Hutchinson. But yeah, you can see it's a little bit clear here. Oh, that's the one I was looking for. Can you see it looks gray or clear even? Like it's kind of transparent. This is osteogenesis imperfecta. No dentine basically. So yeah, because they wear up easy because they don't have dentine, the outer layer. So not the animal. Under the animal, there is some layer called the dentine, that layer. Also, they can have hearing loss because of a problem of the ossicles of their ears. So do not confuse it with child abuse. Keep in mind these patients can have multiple fractures that do not make sense. Like my son fell from the table and he broke 6 bones. So it's kind of suspicious, but also keep it in mind. You need to treat it with bisphosphonate to decrease the risk of a fracture, and the patient cannot bite, which means multiple fracture, blue sclera, dental imperfections, and hearing loss. Okay guys, see you in 10 minutes. Okay everyone, welcome back. So as I was speaking, we were speaking about osteogenesis imperfecta, and that was mainly type 1 collagen defect. Now I'm going to move forward and start speaking about Ehlers-Danlos Syndrome. Keep in mind that in cases of Ehlers-Danlos Syndrome, we have 2 types. We have the vascular type and we have the musculoskeletal type. Regarding the vascular type, it's a type 3 collagen defect. The musculoskeletal type, it's type 5. So Ehlers-Danlos Syndrome, it's a faulty collagen synthesis causing hyperextensibility of the skin and hypermobile joint. So it's these guys in the circuit who can twist their bodies in a weird way, hypermobile joint, and also the hyperextensible skin. Keep in mind, if your patient has lost significant amount of weight recently, this does not count because it's just extra skin. And also these patients have an increased tendency...
Doctor, I think you're on mute.
Oh, okay. Thank you. So I was speaking about Ehlers-Danlos Syndrome. Can you hear me right now? Excellent. So, Ehlers-Danlos Syndrome is subdivided into 2 types. We have the vascular type and we have the musculoskeletal type. The musculoskeletal type is mainly a type 5 collagen defect, while the vascular type is a type 3 collagen defect. Okay? So if we are speaking about the type 3 collagen defect, which is vascular, you are going to see that mostly the problem will be in the vessels, obviously, and the internal organs. While in the musculoskeletal type, the problem will be mainly musculoskeletal, so joint/skin. So let's see. Faulty collagen defect synthesis causing hyperextensible skin, as you can see here. Reduction of the weight leading to extra skin does not count, and also hypermobile joint, as you can see here. Also, the increased tendency to bleed, which lead to easy bruising. It has multiple types, so yeah, and the inheritance of it and the severity vary, and this is actually really good. Why? Because as a person who want to do the USMLE, you will never get this question. What is the mode of inheritance of Ehlers-Danlos Syndrome? Well, basically it can be both autosomal recessive or dominant. So it's difficult to get a question about that. It's associated with joint dislocation, most commonly shoulder dislocation. Also, peri and aortic aneurysm and organ rupture. So I will explain which one is associated with what, and I'm saying that because, as I said, there is different type. So first of all, there is the hypermobility type, which is the most common type, and it's just these people who can twist their joint, okay? So they just can, like when they do a thumbs up, their thumb goes back. Like when we do thumbs up, we do something like this. So that's our thumbs up, but their thumbs up is something like this. Yeah, kind of weird. So they can do it all the way like this. This is a sign of Ehlers-Danlos Syndrome and the hypermobility. Also, the classical type, joint and skin symptoms, in which it's a type 5 collagen defect. It's the COLA 5, and these patients are also going to have this and the hyperextensible skin. Finally, the one that they like on the exam, which is the vascular type. The tissues and the vessels, both of them will be really fragile, so they are at really high risk of rupture. For example, they can have rupture of the aorta, which can lead to massive bleeding and death within 10 seconds. Also, they can have muscles defect, and also, except of the muscles, they can have organ rupture, especially the gravid uterus. For example, the lady is pregnant, first trimester, no problem. In the second trimester, towards the ending of it, the baby is now large and the uterus is really sensitive. So the baby becomes big, rupture. The uterus ruptures. And with the uterus rupture, all of these product of conception will be inside of the abdominal cavity, which promote to peritonitis. Okay, so mutation, it's in the COLA 3. So type 3 collagen. Okay, so to sum it up, Osteogenesis Imperfecta, type 1 collagen. Ehlers-Danlos Syndrome, 2 types. The musculoskeletal type, which is type 5, and the vascular type, which is type 3. They have organ rupture, and they also can have peri aneurysms and aortic aneurysm. In case of aortic aneurysm, can you tell me please which valvular disorder you can have? In case, yes, regurgitation of the aorta, absolutely correct. So the next disease is about Menkes disease. Menkes disease is a deficiency of the copper. So it's an X-linked recessive connective tissue disease, which is caused by an improper copper absorption and transport due to a defect in the Menkes protein known as ATP7A. I know that it's kind of confusing because we had ATP7B, which we studied in GIT regarding Wilson disease. But remember, Wilson disease was a buildup of kappa, not a reduction of kappa. I personally just remember that Menkes disease is explained in the beginning of the book. That's why it's ATP7A, while Wilson was in the end of the book. So that's why it's an ATP7B. So it can lead to decreased activity of lysyl oxidase, which, as we said, was the thing responsible of doing the cross-linking between the tropocollagen. Without the cross-linking between the tropocollagen, we will have no cross-linking, which means a defect on the mature collagen. So less lysyl oxidase, copper is unnecessary cofactor for lysyl oxidase, will have a defect in the collagen. So we can have this kinky hair, which is like this. Let me show you kinky hair. So they can have this kinky hair, which is like a twisted type of hair. I'm not speaking about just like a person who did it on intention. I mean someone who already normally had like smooth hair and then got the kinky hair suddenly, which is kind of weird. And in the babies, as you can see, can you see the kinky hair? So that's characteristic of, yeah, Minky's disease. Okay, defect on the cover. So they can have growth or developmental delay, also hypotonia, and most importantly, they have high risk of cerebral aneurysm. I know you did not learn this yet, but you must know that cerebral aneurysm is happening within the cerebral artery, and any rupture of them will lead of which type of hemorrhage? Is it epidural, subdural, or subarachnoid? You must know that it will be subarachnoid, okay? And thus, because it's subarachnoid, when you do an LB, a lumbar puncture, will you see blood or no? I want you to know that between the subarachnoid space and the area around the spinal cord, which contain the fluid, they are totally connected with each other, which means if a subarachnoid hemorrhage occurs, the lumbar puncture will also show blood. But if we have the epidural or the subdural type of hematoma, the subdural will show, the lumbar puncture will show no blood in epidural and subdural, only in the subarachnoid. Okay, so that's for cerebral aneurysm, and it's actually the most common cause of death. The next topic is regarding elastin. Elastin is quite interesting because when you think elastin, you need to think fibrillin. Why? Because elastin, yeah, it's nice, all of that, but basically it's the same story as collagen, except a few exceptions, like a few changes. It's basically collagen, but not exactly collagen. While fibrillin, it's totally different. It has a different function, and a really interesting function that I'm going to explain now. So let me just show you this. Let's say that this is elastin, and yes, this is elastin. Around the elastin, we have something called a scaffolder. This scaffolder is basically a type of structure that keep everything in place. I don't know if any of you worked in the building industry. Scaffolding, yes. So for all of you who work in the building industry, you know what I'm speaking about. It's this scaffold. We put it in the outside of the building so we can just use it to do the work on it. And after we are done, we can just simply remove it. So yeah, scaffolds are really nice for keeping everything in place. Well, why I'm speaking about them in medicine? Well, the red structure here is elastin, while the blue structure here is fibrillin. So if we speak about the absence of fibrillin, okay, let's say I don't have fibrillin. Fibrillin is the thing keeping elastin in its place. Elastin is elastic. It normally like to keep stretching. It does not like to contract, but opposite. It like to stretch. So if fibrillin is absent, look what happens to the elastin. No fibrillin, the elastin is going to be much wider, okay? Well, this is kind of serious. Why? Because if the elastin is much more wider, this will lead to this Marfanoid habitus, longer limbs. Not only longer limbs is not the main problem actually, but longer everything else. Basically, if we speak about the chordae tendini, which are the type of tendons holding the mitral valve in its place, if they get defected, they get this absence of fibrillin. What is going to happen to the length of chordae tendini? What happens to the length of chordae tendini? So yeah, they will have more length. So if we imagine, if we just try to imagine that this is like the left ventricle, you know, and this is just the mitral, right? And the chordae tendini, if they say this is the muscles and this is the chordae tendini, and now they are like here and they attach into the valve. And let's say that something happens and now like no fibrillin, so this will be much more lengthier. So they are going to precipitate to mitral valve prolapse. That's why a patient with Marfan syndrome have high risk for mitral valve prolapse. Ehlers-Danlos. Elastin. Elastin is a stretchy protein within the skin, lung, large arteries, elastic ligament, vocal cords, epiglottis, and ligamenta flava, which is actually this one is important. I will show it to you now. Flavum means yellow. Ligamentum flavum is one of the ligaments located posteriorly into the vertebral canal, and for the sake of reaching the subarachnoid space, you must penetrate him. So it connects the vertebra, and it has two formation, relaxed and stretch conformation. Let me show you the ligamentum flavum, also known as the yellow ligament. It's located posteriorly in the canal. As you can see, this is the vertebral canal, and this is located posteriorly in it. So again, when you do lumbar puncture, you must penetrate him. So let's move on. The elastin is rich in the non-hydroxylated proline, glycine, and lysine residue, versus the hydroxylated residue, which are located more in case of collagen. So remember, in the collagen, we used to hydroxylate what? Lysine and the proline. Glycine was never hydroxylated. And the glycosylation process happened to the hydroxylysine or proline. Can somebody tell me? Did we glycosylate the hydroxylysine or the hydroxyproline? Come on. So as we spoke about, the only one that was glycosylated was the hydroxylysine. Lysine, it has an S. So lysine is the only one that is glycosylated. Okay, so tropoelastin has a fibrillin scaffolding which keeps it in a place. Cross-linkage take place extracellularly and give elastin its elastic property. So the cross-linking is the thing responsible for the elastic property in the case of elastin. Okay, so broken down by elastase, which is normally inhibited by something called alpha-1 antitrypsin. Always when you see alpha-1 antitrypsin, make a bracket right between them, proteinase. Okay, why I'm saying that? Because alpha-1 antitrypsin is just an enzyme that is responsible for breaking down proteins like enzymes. So enzyme that can break down other enzymes. Well, which enzyme does it break? The answer is elastase. So alpha-1 antitrypsin deficiency and alpha-1 antitrypsin and elastase is like a scale, two-hand scale. One has elastase and the other one has the protease, which is the alpha-1 antitrypsin. So they write here broken down by elastase, which is normally inhibited by alpha-1 antitrypsin. Alpha-1 antitrypsin deficiency results in an unopposed elastic activity, which can cause COPD. Okay, so they can have this unopposed elastic activity, which can lead to COPD. Good. So, okay, well, what is the big deal? Well, let's take a look. Basically, when we have nothing to break down the elastase will be working extra shift. And when the elastase is working a lot of time, he will be breaking down all of the elastin. No elastins means that the lung will be having less tendency to collapse, and now we will have a form of COPD. We'll speak further about it, about how it happens exactly when we discuss COPD. But two things I want from you for now is, number one, the place where is alpha-1 antitrypsin produced. And I want you to know, excellent, it's produced by the liver. It's produced by the liver, absolutely correct. And the second thing that I want you to know is that in case of COPD, we have a problem in exhaling, not inhaling, okay? So changes with age, the elastin they mean. So we will have less dermal collagen and elastin, and decreased synthesis of collagen fibrils, and the cross-linking remains normal. This is actually important. You must know that the cross-linking remains normal. However, the amount decreases. Why this is important? Well, guys, if you take a blood for an old person versus a young person, which one tend to be more difficult to take a blood from? A young person or an old person? The answer is old. It's definitely old. Why? Because their vessel, if it was here, if let's say that this is the skin, for a young person, you have a lot of collagen, you have a lot of subcutaneous tissue, which are holding the vessel in its place. So when you put the needle, done, no problemo. But for an older human being, they have a lot of space, you know, so you try to put the needle and the vessel start moving with you. It becomes wiggly. So this is kind of, messy. And sometimes you can sadly stick the patient 3-4 times until you get the vein. So yeah, that's because of a decreased dermal collagen and elastin and decreased collagen fibrils. Now we have Marfan syndrome and Hemosystenoria. Let's start with Marfan syndrome. It's an autosomal dominant disease with a variable expression, connective tissue disorder affecting the skeleton, heart, and the eyes. So this disease can lead to multiple problems, including the skeleton, the heart, and the eyes. For each of these, I will tell you what you have to know when we reach them. So FBN1 gene mutation, it's located on the chromosome 15, lead to a defect in the fibrillin, which is the scaffolding protein we spoke about. It's a glycoprotein that form a sheath around the elastin, as I draw for you, like this shape, the blue one, if you remember. Around the elastin and sequester the TGF-beta. We'll see the function of the TGF-beta in a moment. Remember, TGF-beta was highly responsible for the process of regeneration and repair. So finding tall with long extremities. Why? Because no more scaffolding, so everything is going to become much more lengthier. Okay, so they will have also chest wall deformity, something known as pictus carnatum, also known as the pigeon chest, or so the pigeon chest is like this, while the excavatum is vice versa, which is like this. So pigeon chest, not pigeon chest, excavatum. So they can have hypermobile joint, long tapering finger and toes, also known as arachnodactyly. Arachnodactyly, the exact meaning of arachnodactyly, it's a finger that looks like a spider. So if you take a look at their fingers, they are really long, they are kind of like a spider, okay? So one clinical test you can do during your shifts, just like, I hope I will find it here. Yes. Tell your patient to do this. In a normal human being, you should barely be able to touch them, maybe a little bit go over them. But if you can't go all the way, this is a positive sign of arachnodactyly. Also, when we put our thumb inside of our hand and close on it, we normally we should not have it going to the other side, guys. This is too much. I mean, when you cover all of your fingers on it. But if they can't do it, this is a sign also of arachnodactyly, which is highly associated with Marfan syndrome. Okay. So hypermobile joint, we spoke about arachnodactyly. Also cystic medial necrosis of the aorta due to the defect in the TGF-beta. So because of that, we can get an aortic root aneurysm rupture or even dissection. Remember, rupture is just the whole aorta was burst and you will die in seconds. While dissection was like only the tunica intima was rupture, which led to the blood going under the tunica intima, which led to dissecting the tunica intima from the media. It's the most common cause of death. Mitral valve prolapse lead to, why? Because we have more lengthier chorda tendini. And finally, increased risk of spontaneous pneumothorax due to formation of blips. So you are like, wait a second, what is a blip? So a blip of the lung is something like this. It's a sac of air that will be inside of the lung, as you can see here. And it can just suddenly burst. When it bursts, it leads to spontaneous pneumothorax, not a traumatic pneumothorax. So this is an example of a pulmonary blip which can be existing in case of Marfan syndrome. So the next one is about Hemosystenoria. Why the hell it's even mentioned here? Because it has so many symptoms similar to Marfan syndrome. That's why it's mentioned here. So in Hemosystenoria, the presentation will be similar to Marfan syndrome with victus deformity, tall stature. So they will have more arm to height ratio and less upper to lower body segment ratio, which means their arms are really, really long compared to their height, regardless of the fact that they are still tall. And they have less upper to lower body segment, regardless of the fact that both of their hand and legs are tall, their legs are taller. But guys, it's still the same as Marfan. Do not confuse it. Don't think it's different. It's exactly the same as Marfan. Also, they have the arachnodactyly. Also, they have the joint hyperlaxity. Also, they have the skin hyperelasticity. And also, they might have the scoliosis. You are like, wait a second. So what is different? That's why they made the table. Because only few things are different. Otherwise, it's exactly the same. So in Marfan syndrome, it's autosomal dominant. Hemosystenoria, it's recessive. The intellect in Marfan is totally okay. Hemosystenoria, it might be decreased. Now, this is the important point. The vascular complication. Why is the most important point? Because it's what killed them. So these two are actually the most important. One, help you for making the diagnosis, and one, help you making the prognosis. So the one that help you make the prognosis is, vascular complication, Marfan syndrome, aortic root dilatation, which can promote aortic regurgitation and also can have aortic dissection in these patients as well, or even an aneurysm rupture. While in hemocysteinuria, they do have a hypercoagulable state because the homocysteine is basically a substance that can lead to endothelial dysfunction and promote to formation of thrombosis, which can basically kill the patient. Yeah, so it can increase the risk of strokes, MIs, kidney infarction. And do you know which vitamin deficiency can lead to hemocysteinuria? I'm not speaking about the inheritable one. I'm speaking about an acquired one. An acquired type of vitamin. Not vitamin K. It's actually vitamin B12 and what else? And also, no, it's not PH4. That's a totally different disease. That was phenylketonuria. That's different. It's B9, absolutely correct. It's B9 deficiency. Yep, B9 and B12, both of them have the hemocysteinuria. But to differentiate between them, there is something called methylmalonic acid, which is the difference between them. It will be higher in which one? The B12, exactly. So this is how you differentiate between the two. Don't worry about it. We'll speak about it in nutrition. The lens dislocation. I will show you what does it mean. Lens subluxation. So remember, lens is a type 4 collagen. Anyway, it's not irrelevant for this topic, but yeah, you can see that this patient. Let me search for this guy. Okay, this guy. Subluxation, is it going up or down? The subluxation, is it up or down? Absolutely, it's going down and in, down and in. When the subluxation is going down and in, this is a sign of hemocysteinuria. Okay, so it's hemocysteinuria. When it's going up and temporal, this is a sign of Marfan syndrome. So let's search for somebody. Just a second. Nice, okay. So this guy, for example, you can see it's going up and to this side. As you can see, this is the lens. And this is what? This is Marfan. Marfan. Okay, so yeah, lens dislocation in the case of Marfan, it's upward, while in Hemosystenoria, it's downward. Okay, so that's it for Cellular. We are done with Cellular in 1.5 hours. Excellent. Good. So we are done with the cellular biochemistry. The next thing we have is lab techniques. For the lab techniques, I will be explaining you. First of all, I want you to make the following notes. This is high yield. This is low yield. This is high yield, high yield, high yield, high yield. Super high yield. Totally low yield. High yield. High yield, high yield. Low yield, low yield. So some of these stuff you must master. Some of these stuff are totally useless. For example, nobody will ever ask you about microarrays or molecular cloning or gene expression modification. I don't even know them that good. Nobody will ask you about these. But if you speak about karyotyping, FISH, BCR, ELISA, flow cytometry, everybody's going to ask you about this. In your step, you will get a question on one of these. So to be crystal clear with you, I'm not going to explain this concept and this concept. You can read about them online, or I can suggest some articles. Basically, I don't understand them fully, so it's difficult for me to explain it for somebody else. But for the other topics, all of the other ones except these two, I will be explaining them fully. But this is for another class. For today, we are going to start with something new, and that will depend on your decision. I will make a poll right now, so we'll take a 10 minutes break, and during the 10 minutes, please answer the poll so I know what I have to do next. So see you in 10. رياض، كيف حال شركة الألبان اللي عندك إياها؟
في نقص في الحليب.
عندكم نقص بالحليب؟ عندنا ننتين بالثلاجة. روح عمل لنا لبنة وتعال. خواص لبنة ايش؟ شو احكي؟ شو just okay, so yeah, general pharmacology. General pharmacology tend to be one of the most difficult portion of the USMLE. Not because it's difficult, but because it has mathematics. And anytime there is mathematics in something, people stop to think, and it has a lot of graphs. So, to be fair with you, this page is a little bit confused. This page tends to be the most confusing for a student. This tends to be the second most confusing, conveniently, third most confusing, fourth most confusing, and it becomes less and less and less until you reached here, which is mean everything else after this is easy. But my job for today is to explain at least for you this page and this page, and at least like this page and from this page to finish these, because they tend to be difficult things that you must master. Okay, so let's take a look. Michel's-Menten kinetics. So the Km is inversely related to the affinity of an enzyme for its substrate. Let me make sure that you even understand what I'm speaking about. So this is an enzyme. Enzymes are proteins. Proteins made up of amino acids. So these enzymes, for each enzyme, it has two sites. It has a site that calls the active site, which is this one, and it has a site that is called the allosteric site, which means the other site, okay? So it has an active site and an allosteric site. So Km is inversely related to the affinity of enzyme for its substrate. So the higher the Km, the less the affinity. The higher the Km, the less the affinity. So normally the substances are going to bind to their active site to activate the enzyme to convert the substrate into a product. So here they write the definition of Km, it's related to the affinity inverse relationship, which means if you get high Km, low affinity. If you get low Km, high affinity. Okay, what about Vmax? It means how much is the concentration of the enzyme inside of that, well, inside of the blood, for example. So the Vmax is directly proportional to the enzyme concentration. So let's say I have 1 liter of fluid and I have 10 particles of enzyme in it. And I have another type of fluid in which it has 5 particles of the enzyme in it. That means the fluid with the 5 enzyme in it has much lower Vmax than the 10 enzyme in it, okay? So Vmax is the concentration of the enzyme, while the Km is the affinity of that enzyme. Okay, so most enzymatic reaction follow the hyperbolic curve of the Michel's-Menten kinetic. What does the word hyperbolic mean? It's this shape. Anytime you see this shape, it means it's hyperbolic, okay? So just for the sake of USMLE, this is hyperbolic, this is linear, and this is sigmoid. Okay, so we have sigmoid, we have hyperbolic, and we have linear. So this is the hyperbolic one. Enzymatic reaction that exhibit a sigmoid curve usually indicate cooperative kinetics, like hemoglobin, for example. So hemoglobin does not have a hyperbolic curve, it does have something called a sigmoid curve. Let's take a look at the sigmoid curve. So this is hemoglobin, oxygen dissociation curve. As you can see, in hemoglobin we have this type of curve, which is sigmoid. How come? Why do we have a sigmoid curve? The answer is because of the cooperativity of the hemoglobin. Remember, hemoglobin does have how many heme in it? Well, I hope you know that it has 4 hemes in it. And each heme is going to bind to at least 1 oxygen, right? So it has 4 heme particles. Each of them is going to each of them has iron, which is going to bind to oxygen. But something interesting happens. After binding the first one, the affinity of the hemoglobin is going to increase. Affinity is high. That means the Km is going to go down, right? Because it's an inverse relationship. So, okay, one has bound. So the Km now is going down. Why? Because affinity is higher. So now one more is going to bind, right? So the Km is even lower and the affinity is even higher. This is what creates the sigmoid curve. Notice, initially it's slow binding, but by the time you add more stuff, you have cooperativity, which means one binding enhances the other binding, right? And that will lead to something like this. This is cooperativity, right? And one more O2, this makes it even more, and finally one more O2. Now it's saturated. As you can see, when it's saturated, it plateaus. Okay, so that's the hyperbolic, and that was the sigmoid one. So they write here the velocity of the reaction. So you can see here the Vmax, which is tightly proportionate to the enzyme concentration. So if I make 2 curves, one the green one and the orange one, The green one has much lower Vmax than the orange one. Okay, so the Km, however, it's in the other axis, and it basically, there is another way of calculating it. It's the Km at half Vmax. So when you want to calculate the Km for something, it's easy. Just look at the Vmax, take half of it, and make a direct line and go down. You will find it. Okay? So that is the Km at the half of Vmax. So effects of enzyme inhibition. Let's inhibit this enzyme and see what happens. We have commutative inhibitor and a non-commutative inhibitor. Again, this is the enzyme, this is the active site, this is the allosteric site. Okay, if we speak about a commutative inhibitor, as you notice, it has decreasing the efficacy of the drug, the potency of the drug, but eventually, if you add more substance, you will be able to overcome it. I mean, if you add more of the substrate, you will be able to overcome the commutative inhibitor. So let's just say that this is the square is the agonist and the triangle is the antagonist. So they will be fighting for each other, 50-50 type of thing. But if I add more agonist, the antagonist will have much less chance. Now it's, instead of 50%, now he has only 25% of kicking this one off. So what I mean that by increasing the substrate, you can eventually overcome the commutative inhibitor. That's why they show that the Vmax can still be reached, but it takes much more time than without the commutative inhibitor. So the commutative inhibitor just delayed the reaching of Vmax. A non-commutative inhibitor basically destroys the enzyme by one of two mechanisms. The first one is irreversibly binding to the to the active site and destroying it, or binding to the allosteric site and destroying the enzyme himself. By destroying the enzyme, what will happen to the enzyme? Is destroyed. So the concentration of the enzyme is going to go, if you destroy it, the concentration is going to go much lower. It's going down, right? So when the enzyme concentration goes down, the Vmax is also going down, as you can see. So a non-competitive inhibitor which destroys the enzyme, the Vmax for it will be much lower. Okay. So that was the Michels-Menten kinetics. Anytime mathematics people see that something started to make sense, they start to want to put a logarithm in it. I don't know why, but they like it. Actually, I know why. So why they like to put the logarithm? Because it converts curves. To convert curves to lines, you need logarithm. Okay? So it's just a mathematical trick to convert this shape into this shape. To convert curves into lines, you must put logarithms. So let's take a look what they have done. They put a logarithm, and now they had linear shapes, okay? So the closer to 0 on the y-axis, the higher the Vmax. So this is the y-axis, and this is the x-axis, okay? So they write, the closer to 0, the higher the Vmax. Because here, as you can see, we have inverse relationship, which help also creating the what? The linear relationship. So let's take a look what they write here. So the closer you are to 0, if we say like line number 1 and line number 2, line number 1 has much higher Vmax than line number 2. Who has more concentration of the enzyme? Line number 1. Okay, so now we are just speaking about the y-axis. So the closer to 0 on the x-axis, the higher the Km. So the closer you get to the Km, to the 0, the higher the Km, which is the inverse of the affinity, which means when I am here, this is 1 and this is 2. At 1, Km is much higher, but the affinity is much lower because Km and the affinity has an inverse relationship. Again, 2 versus 1. 2 has much lower Km. Why? Because it's much more far than 0. Thus, since 2 is far away, Km is much more lower. So the affinity is going to be much more higher. Okay? So the affinity is going to be much more higher. I'm recording this session. If you did not understand something, I highly recommend that you replay this one again, because I know that this topic, it's not easy to understand it from the first time, but basically I'm going to teach you everything you need. If you don't get something, it's totally okay. Just revise the video and you will get it. Okay, so the closer to zero on the x-axis, the higher the Km. The higher the Km, the lower the affinity. Competitive inhibitor cross each other, whereas non-competitive inhibitor do not cross each other. What do I mean? So if you take a look at this one, so notice what is happening. You can see the green line and the, first of all, the uninhibited. This is the normal, without anything. If we speak about competitive inhibitor, see, they are crossing each other at some point. But non-competitive inhibitor is totally not related to them. A couple of more things we can appreciate from this picture. If we are speaking about competitive inhibitor, the Km for competitive inhibitor is much more higher. So that means what is happening to the affinity when the Km is going up? When the Km goes up, the affinity is going down. Absolutely. So it's going down. Okay, good. So yeah, competitive inhibitor affinity is going down. Now also we have this line. In a competitive inhibitor, the Vmax is exactly the same. And that is true as we spoke about it here. Remember, the Vmax was the same. You only needed more substrate to reach the exact same Vmax. You did not destroy the enzyme in case of a reversible competitive inhibitor. In a non-competitive inhibitor, however, it does not really affect the affinity of a singular subunit of an enzyme because it just destroys one enzyme at all. But his brother, the other enzyme, affinity will be exactly the same. It will not be affected. So the affinity is not played at all in non-competitive inhibitor. But since he breaks down the other enzyme, the Vmax is going to be much more lower. And you remember in the linear curve, it's an inverse relationship. So lower means higher on the y-axis. Now when you look at the table, you have competitive inhibitor, which are reversible, competitive inhibitor, which are irreversible, non-competitive inhibitor. So let's take a look. So let's make this enzyme here and put this. So competitive inhibitor, do they resemble the substrate? Yep, absolutely. Competitive inhibitors, the irreversible one, do they mimic the substrate? Absolutely. Non-competitive inhibitor, not really. Why? Because they bind to the allosteric site, not to the active site. Okay? So that's why they don't mimic the substrate, because they totally bind to a different location, which is known as the allosteric site. So can they be overcome by the substrate? Well, the reversible one, obviously. Irreversible one, obviously not. Non-competitive, basically they destroy the whole enzyme. So yeah, you cannot reverse it with adding more substrate because you don't have more enzyme. Bind to the active site, the competitive, both of them do. What about the non-competitive? Well, that was the main function. It binds to the allosteric site, so he does not. Effect on the Vmax. Competitive will not be changed, but these two just destroy the enzyme. So it will decrease in both of them. Effect on the Km. So the Km, which is the affinity, so this guy is increasing Km, which decreases the affinity. While in these two, we are increasing the affinity of the other guys. But no, so there is something wrong here. Oh, I made a mistake. I misunderstood. I mixed this one with this one. Yeah, I felt it because this does not make sense. So the irreversible one will destroy the enzyme. But let's imagine we have a 3 enzyme subunit. If you destroy one of them, the other 2 will be still functional. Still functional means that their affinity is untouched. The pharmacodynamic, however, how do they play with the potency versus the efficacy and all of that? Competitive inhibitor decreases the potency. Potency is how much a drug needed to lead to an effect, a pharmacological effect. While the efficacy is how much a drug do you need to get to reach the Vmax. So basically in both the these two guys, which totally irreversibly destroy the enzyme, we are decreasing the Vmax. Thus, the efficacy goes down, because this is the definition of efficacy. The lower the efficacy, this is exactly what we learned. The lower the efficacy, the lower the Vmax. Okay? So, yeah, that's it for this page. If you did not understand it, just rewind the videos and it all makes sense. Actually, I did the same when I used to learn it. I just watched one video maybe 15 times until I got it. So now we have the pharmacokinetics. Before I start with these concepts, I know that your brain has been exploded. So let me just take 6 minutes break with you guys, and I will see you guys in 6 minutes. Hi guys, welcome back. So let's finish up this. We have pharmacokinetics versus pharmacodynamics. First of all, I need you to understand the general concept of pharmacokinetics. Pharmacokinetics means the drug, how is it absorbed, then metabolized, then utilized, then cleared. So, when we speak about the drug, first of all, how is it absorbed? Mode of insertion of it inside of the body. Is it IV? Is it oral? Is it sublingual? Is it intramuscular? Is it subcutaneous? Is it rectal? Is it vaginal? All of these may have some differences between them. And when you speak about something, a concept called bioavailability, the meaning of bioavailability is how much of the drug that you administered did really reach the circulation. I mean, if I give something IV, I'm putting it directly into the circulation. So the amount that I have put, it's the same amount it will be in the circulation. So 100%, the bioavailability. But if I give something oral, it's going inside of my intestine, then absorbed by the portal vein, then goes to the liver to be metabolized. During metabolization, during absorption, it's going to lose some of this amount. So the bioavailability will be much less. So fraction of administered drug reaches the systemic circulation unchanged. For an IV dose, it will be 100%, while orally, the bioavailability is going to be less than 100%. By the way, bioavailability, we mention it as F. Due to incomplete absorption or first pass metabolism, also known as liver metabolism. It can be calculated from area under the curve in the plot of the plasma concentration over time. So if you take a look at this, this is just giving us if this is the plasma concentration of a drug, if it was given IV or if it's given orally. Notice, in case of IV, it's 100% originally and it descends. But in case of oral, well, it's initially nothing, and then the amount, it starts increasing, and then it reaches the peak, then it starts clearing until there is nothing. Okay? So, volume of distribution. How much of the drug made it into systemic circulation? That was bioavailability. Now we are going to say to which compartment was the drug distributed to. I mean, we have the extracellular, we have the intracellular, we have the blood, we have multiple compartments in our body. To which compartment it was going to. By the way, if you wrote cytochrome B450, that was the first pass metabolism, you are right. So, volume of distribution, a theoretical volume occupied by the total amount of a drug inside of the body relative to its concentration of the plasma. So, apparent volume of distribution of a plasma protein bounded drug can be altered by liver and kidney disease. Let me explain. If I'm speaking about a drug such as warfarin, warfarin does bind to the albumin in the blood. So if I have liver dysfunction, the amount of albumin is going down. If I have kidney dysfunction, why? Because liver synthesizes the albumin. If I have nephrotic syndrome, the amount of albumin is also going down. So less amount of albumin means more free warfarin, right? More free warfarin, more efficacy of the warfarin. Because what is the more active type of a drug? Is it the bound or is it the free? What is more active, a free drug or bound drug? free one is more active. Absolutely. Because the free one is more active, the warfarin, when the albumin is down, is going to be more effective, which is not a good thing actually, because it becomes toxic. So less protein binding, more volume of distribution, meaning that it can go to different compartments. A drug may distribute in more than one compartment. Hemodialysis is a more effective for a drug with low volume of distribution, which means they are stuck into the circulation, to the intravascular circulation, but not going into the extracellular fluid, or even worse, which is inside of the cells. So the volume of distribution, when it's really low, that means that it's intravascular. It is stuck inside into the vessels. This is cool. Why? Because these drugs, meaning that they are only acting inside of the vessel. If the pathology is only inside of the vessel, this is what we need. But if it's outside of the vessel, obviously this is not what we need. So yeah, intravascular, it's going to be only inside of the vessels. So these drugs are big in size, okay, which prevent them from going to the extracellular fluid, and mostly they are bound to albumin, and also they are charged, heavily charged. Heavily charged mean it's really difficult for them to go through something. So yeah, they have multiple ions in them and cations, which prevent them from exiting any type of space. So while the medium volume of distribution means that they can reach the extracellular space and can form small hydrophilic molecules. So these small hydrophilic molecules are going to be something like this. They can go to the extracellular space, but they are hydrophilic, which means they like water. If they like water, can they enter the cell? They like water, can they enter the cell? The answer is absolutely not, because the cell wall is made out of phospholipid, and lipid and water don't like each other. So a hydrophilic molecule, yes, it can be in the extracellular fluid, but it cannot enter the cell. While molecules with a high volume of distribution, they can go everywhere. They are small, which means they can exit from the vessel. They are lipophilic, which means they can enter the cell, especially if bound to tissue proteins. So the clearance is the volume of a plasma cleared of a drug per unit time. So volume of a plasma cleared of a drug per unit time. So clearance may be impaired with a defect in the cardiac, hepatic, or renal function. So basically, if the patient is, where do we clear from? Well, basically we can clear from our kidney or from our liver with the bile. Why cardiac play a part in this? Well, if you have less cardiac output, you have less renal perfusion, which means less clearance, okay? So clearance is equal to the rate of elimination of a drug divided by the plasma drug concentration, which means how much are you clearing per minute, dividing by how much drug do you have in your plasma, okay? And there is a formula here, which is the volume of distribution multiplied by the elimination constant for that exact drug. If they're going to ask about this, they must give you the constant. Anyhow, guys, the formulas that you must know for the step 1, all of them are in 2 pages in the rapid review. I showed you them before. So whatever in the rapid review, you must know, otherwise you don't have to know it. So there is like, I highly advise you to brand them and put it in a place in front of you. Like this table, and yeah, this one. That's it. So this is everything you have to know for both pharmacology, biostatistics, all of them. So yeah, if we move on and we speak about the half-life, if how much of the drug is left after like sometimes. So the time required to change the amount of a drug by a half, okay? So let's say a half-life of a drug is 1 minute. That means if you have 1 gram of this drug right now, in 1 minute is going to be 500, in 2 minutes is going to be 250, in 3 minutes is going to be 125, and like that. So the time required to change the amount of a drug in body by half during the elimination. A steady state is a dynamic equilibrium in which a drug concentration stay constant. Okay, rate of drug elimination is equal to the drug ingestion. So to reach a steady state, that means basically that the drug is no more not anymore infectious, you know. It means that he is decreasing in the function. In the first order kinetic, which is something I'm going to explain later, a drug infused at a constant rate takes 4 to 5 half-lives to reach its steady state. Let's try well, something on that. Let's say that you have any drug. You ingested, I don't know, 500 milligrams of paracetamol. So 500 milligram, let's say that the half-life of paracetamol, I don't know, 4 hours. So after 4 hours, how much of the paracetamols are you going to have left? The answer is 250. So that's one half-life. Let's do it again. 2 half-lives, 3 half-lives, 4 half-lives, 5 half-lives. As you can see, after 5 half-lives, it's only 15 milligrams left, which is highly irrelevant. It's a really small amount, so we neglect it basically. It's unimportant anymore. So yeah, we reach a steady state in which this drug is irrelevant anymore. 4 to 5 half-life to reach the steady states. It takes 3.3 half-life to reach 90% of the steady state level. I don't believe that. Let me try. So again, let's take paracetamol again, 500. So divide it by 2. Okay, again by 2. Okay, again by 2. And actually, I need to put like by 0.3. 1.3. Okay, and divide that by the 500. That must tell me less than 10%. Okay, 0.01. So if I multiply it by 100, it's 9.6%, almost 10%. Yes, so basically it takes 3.3 half-life to reach 90% of elimination of the steady state. So this formula, they like it. You must know it. So the half-life is equal to 0.7 multiplied by the volume of distribution, which is something we spoke about here. You calculate it by the amount of the drug inside of the body divided by the plasma. To know the amount of the drug inside of the body, it's actually pretty easy. It's how much you ingested, okay? The plasma drug concentration, they mostly give you in the test. Okay, you have the volume of distribution. What to do now? You must have the constant, which is the rate of drug elimination. It's a constant. They must give it to you, otherwise it's impossible to solve this. And from that, they can be like, okay, you have the plasma drug concentration, you have the rate of elimination of the drug, you can get out the clearance. Now you can plug in the clearance into this formula, and you can take the half-life out of it in case of first order kinetic. So I want you to notice here, after the first half-life, it became 50%, second one 25, 12.5, and finally 6.25, and if you keep going, it's going to be like 3.125 and like that. Basically, the half-life keeps getting worse and less and less and less and less. The half-life is the same, sorry. The amount of the substance is becoming less and less and less and less. Okay, guys, so this is the main things I wanted to explain for you today. Tomorrow we'll keep going with this thing. We'll speak about dosage calculation, and hopefully tomorrow we'll finish the general pharmacology. And hopefully we'll speak a little bit about the lab techniques tomorrow as well. So see you guys tomorrow, and we will continue at the same time. Goodbye, everybody.